I'm Andy from the South Yorkshire Dermoscopy Academy, where we help you become the great primary care dermoscopist you were born to be. In this video, I'll explain what Telederm is, its 1 short-term benefit, 3 long-term side effects, and a 3-point plan if you wish to change your habit. And if you make it to the end of this video, I'll reveal how many days it took for our patients to get the reassurance they sought when the clinician used Telederm. Can you guess how many days that took? Find out at the end.
Training a primary care dermoscopist for every general practice.
Talking to some colleagues about the use of dermoscopy in general practice, they say this: "But Andy, if I have any concerns about a skin lesion, I just Telederm it. Problem solved. What's not to like?" So, what is Telederm?
It's the use of digital images to triage, diagnose, monitor or assess skin conditions without the patient being physically present. In our context today, it means taking a photograph of a concerning skin lesion on the patient and sending it to another service to triage the image. You then await a reply with "it's fine, please reassure patient, let's see them routinely," or sometimes would actually like to see them within 2 weeks.
If a patient came into your consulting room and confessed to using crack cocaine, would you be concerned? "But I only smoke it now and then. Well, I feel stressed or fed up. It gives me a feeling of euphoria. My anxiety plummets and I feel more confident. What's not to like?" And you know what? They'll be right. Why don't we promote crack cocaine to our patients with low mood, high anxiety and poor self-confidence? Maybe it's because of longer-term side effects on that most sensitive organ in the human body, which is the brain. How, you may reasonably ask, does this relate to Telederm? Well, consider this scenario. "Doc, I've got a mole on my arm. It's changing. Could it be cancer?" "Well," says the doc, "I don't know. I'm not sure. I could guess, but I don't want to be wrong. What shall I do? I don't want to miss a skin cancer. I know. I'll reach for Telederm. Ah, that's better. It's someone else's problem now, not mine. Next." However, let's consider the long-term side effects of doing this. What is the essence of good general practice? Well, one part is being a gatekeeper, where we treat 90% of things they can treat in hospital, but do it locally, accessibly, with personalised continuing care at a cheaper price. Telederm is a secondary care solution to a primary care failure. What's the point of you if you're not functioning as a good gatekeeper? Others will ask, can't we replace them with some other cheaper grade of medical staff? Being able to use a dermoscope will enable you to be 100 times better at being the gatekeeper that you are called to be. Secondly, you're missing an opportunity to learn and develop your clinical skills. Take long-term crack cocaine use. Their frontal lobes are damaged and their decision-making abilities are reduced. It's the same with Telederm. You won't develop as a clinician properly because you take the easy route each time, missing an opportunity to learn and develop good skills in skin lesion recognition. In 30 years' time, you'll be not much better than you are now because you've not taken the time to grow and develop in that skill. To your patients, they've got to come back, maybe get a photograph taken, and they've got to wait for a result and worry about that. To your secondary colleagues, there's an opportunity cost. In other words, whilst they're spending time sorting out something you haven't been able to sort out, which you could have if you had a dermoscope, they're having to be taken away from doing other duties, such as seeing their other important routine patients. Then there's the wider NHS costs. Why? Because that service of Telederm has to be purchased from somewhere, so commissioners are having to spend money which could have been spent on something else. There are 3 things you need to do to overcome an addiction. Acknowledge the problem, have some insight. Number 2, create a step-by-step recovery plan. Start learning dermoscopy. Number 3, understand it's a lifelong process. It's a daily journey of good decision making. Am I going to use my dermoscope today? Or I'm going to reach for the Telederm because I think it's quicker, although it's probably not. Consider it a lifestyle change rather than a single event. After my introductory clip again, I'll show you my voyage of discovery, what I learned when we did an audit on what actually happens to our patients when they are referred by Telederm, and it will give you the answer. Have you ever audited your own Telederm referrals? Now there's an idea for you.
Training a primary care dermoscopist for every general practice.
We took 31 consecutive patients referred via Telederm. And the first thing we looked at was how long it took for a patient to get a photograph taken. And the average was actually 14 days with quite a variation. Some we couldn't find the data on, and the range varied greatly. Some doctors took them themselves or got them taken by one of the assistants very quickly. However, some really had a long delay, and this was problems with patients having holidays or failing to turn up to appointment and having to get rebooked. For the photographs then to be sent to the Telederm service and for them to then come back with an answer to us was actually very quick. And that was reassuring to see that that part of the system was working really well. And
perhaps approximately half of the patients, the reply came back saying, "Fine, all is good, reassure patient." The question then is, how long did it take for the answer coming back to the clinician get to the patient? Because ultimately that's what matters, the patient being reassured. And this is what we found. There was actually an average of 17 days. For 3 patients, there was no record. For a few patients, the receptionist had to tell the patient because they came to the desk asking. And again, there was a huge range in the patient then being reassured. And in summary, we found the patient's worry time when being referred to dermatology to be given a benign non-cancer diagnosis was 31 days. In our audit, we also looked at what happened to the half of the patients who went to the hospital, and you can read more about this in detail in the link below this video. However, just to point out that our patients took on average 104 days to be seen in secondary care, and in the end of the day, of the 13 who were sent, only 3 ended up having cancer, and they were all BCCs. So of our 30 patients who were referred, perhaps 10% of them ended up having cancer. Wouldn't it be great, therefore, if when our patients turned up more often, we could say, "Don't worry, it's not cancer." Isn't that what we're striving for? Obviously, you can telederm them, but we need to do the best we can. Now, studies have shown that with the naked eye and without dermoscopy, you have to remove approximately 18 non-cancers or benign lesions to find that one that is cancer, because that's only as good as the naked eye can make things. But if you learn dermoscopy, what happens? That ratio drops down to 4:1 because you can pick up a lot more of the things that aren't cancer and therefore not refer them. And we can reduce all this cost, all this worry, and reassure our patients much quicker. Isn't that what we want to do? Then keep watching the videos and I'll show you how you can do that. At the end of this video, you may be feeling that I feel that Telederm is a bit like a vampire and that a dermoscope is the wooden stake that needs to be driven through its heart in order to kill it. And in one sense, in an ideal world, Telederm wouldn't be needed. However, we live in the real world. Often I look at something and I don't know. So I will do a kind of Telederm, but we call it advice and guidance. And that means you take some nice pictures, macroscopic, close up, well focused, and then dermoscopic pictures, ideally polarized and non-polarized, to send to your colleagues in secondary care to say, "Here, this is what I think, what do you think?" Then they'll be able to triage it much better for you. You will also learn. What you now say to the patient is very important. What I say is, I think it's okay, but what I'm going to do is take some pictures now and I'm going to send them to my secondary care colleagues. The consultants at the hospital will have a look and see if it needs to be looked at further. I will contact you back within a week. If you've not heard from me in 2 weeks, please phone up, leave a message and I'll call you back and I'll chase it up for you. In that way, you provide care, continuity of care, and the patient is not going to slip through the gap. Thank you for watching this video and I hope it's been thought-provoking for you, and I'll welcome any comments in the section down below. Training a primary care dermoscopist for every general practice.